بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وأصحابه أجمعين. Our lecture today about treatment planning for implant restoration, general consideration. This lecture is one of the most important lecture in our course because in this lecture we will talk about how to create our complete treatment plan for implant placement. The treatment plan should begin with a clear idea of the end result, which should fulfill the functional and aesthetic needs of the patient. For that, our treatment plan must be, first of all, realistic, واقعية. Second, predictable. We should be able to predict or to expect the success rate and the final result of our treatment plan, and our treatment plan must be readily maintainable, قابلة للصيانة بشكل دائم. Our treatment plan must be realistic, predictable, and readily maintainable. The dental implant can replace single tooth restoration. If we have a single missing tooth, we can use dental implant to replace this tooth as you see in the pictures. The dental implants can support fixed bridges. If we have multiple missing teeth, we can use at least two dental implants to support fixed partial denture. Or if we have full edentulous arch, we can use some number of implants to support complete fixed denture as you see in the pictures. Dental implants also can support removable denture. A lot of removable dentures has problems in the stability and the retention due to bone resorption in several areas of the jaws. If we use two implant or more than two implant to support or to support attachment to fix this removable denture, we can solve the problems of this removable denture and improve the aesthetics and the speech and the function of this dentures. In a small summary, dental implant can solve the problem of single missing tooth or multiple missing teeth or full edentulous arch, and dental implant can support single tooth restoration or fixed bridge prosthesis or support removable denture. For that, always we should assess the patient needs and desire. We should know the chief complaint of the patient. We should include other alternative solutions in the discussion with the patient. We must not tell the patient you have one treatment plan only. Okay? If you don't put implant, you will die. No, it's not the truth. If you don't want to use dental implant, we have another alternative treatment options. We should always design the prosthesis first. This is very important note. We should always design the prosthesis first. Okay? I will talk I will give you my statement. Design the prosthesis first. Start from the end. What is the end? The end is the prosthesis. We should design the prosthesis first. After we design the prosthesis, we will see what is the options to reach this design or to reach this final result. Patient want teeth. Patient doesn't want implants. Patient want function. Patient want aesthetics. For that, the implant prosthesis must drive the treatment plan, not the implant itself. As I told you before, start from the end. The end is the prosthesis. We will design the final prosthesis. After that, we will see what are the options to reach this final result. Evaluate our cases or our patients or our treatment plan. We should evaluate the functional and aesthetic requirements of our patient. We should make our clinical examination, extraoral and intraoral examination. We should have study cast and diagnostic setups or workshops to see the final prosthesis, the final design of the prosthesis, and we should have enough radiographic examination about our cases. We will talk about the aesthetic considerations of our treatment plan. What we mean about aesthetic considerations? Aesthetic considerations means how much of the anterior teeth is revealed or shown during the functional and the smiling. We should evaluate the degree of bone resorption, and we should evaluate the facial contour and lip support. All of this assessment or examination to evaluate the aesthetic considerations of our patients. For example, about the aesthetic considerations, how much of the anterior teeth is revealed or shown during function and the smiling. In this case, we see there is no aesthetic problems on smiling and normal function of this patient because he has or she has low lip smile line. That means we can't see except part of the teeth during the smiling and the normal function. This is the same patient after we retract her lips. We can see that this patient has implant in the area of 2-1 with gingival recession in this area and some gingival or degree of gingival recession in the adjacent teeth 2-2 and 2-3. If the patient has low smile line, that means there is no aesthetic problem during smiling and during the normal function. If the patient has low lip smile, that means low lip smile line, that means we can leave this patient as is. It's not necessary to treat this problem if the case is stable, if the implant is stable without mobility, without bone resorption. حتى لو كان في عنا some gingival recession in the area, because the patient has no problem aesthetically. But if this patient has gummy smile or high smile line, in this situation we should consider this problem as significant a problem, and we should solve this problem by remove this implant or and graft the area. After that, we should make gingival grafting after we insert another implant. The previous case was an example about the realistic treatment plan. If we have a problem in the case and we don't have aesthetic problem during the smiling and normal function, we can leave the case as is if the implant is stable and there is no significant problems in the case. This is another case about the aesthetic consideration. This patient has missing maxillary lateral incisors. Okay? For a treatment plan, first step of our treatment plan, we will prepare partial denture to evaluate the aesthetics of the final prosthesis. After we prepare the partial denture, we will ask the patient to wear this denture for the patient see the final result, and we will evaluate our final result. The picture in the bottom, number C, we can see we insert 2 implants in the area of 1-2 and 2-2 with 2 implants to replace the missing lateral incisor with excellent aesthetic result. In this case, we can see that we design the prosthesis first. We start from the design of the prosthesis first. After we design the prosthesis first, we see the treatment options and we chose the implant to replace the missing teeth, and in the end we could have excellent final aesthetic result of our case. Also, we should evaluate the degree of bone resorption. In this case, we see we have patient with missing teeth in the area of 2-1 and 2-2. It's clear that we have severe bone defect and bone resorption in this area. We should start from the end. How we start from the end? We should design the prosthesis first. In this case, we prepare removable denture to evaluate the degree of bone resorption in this area. After we design the prosthesis, we can see how much in the picture in the bottom. We can see that we need to rebuild this area of bone and soft tissue before implant placement to have excellent aesthetic final result. One of the important assessment is to evaluate the lip support with or without prosthesis. How can we evaluate the lip support? We can see the profile of the patient. We can see the profile of the patient without prosthesis or with prosthesis. In this assessment, we can see if the patient without the prosthesis has depression in the lip. That means we should prepare or design a prosthesis that support the lip and push the lip. If we have good lip support without the prosthesis, that means our problem only in the missing teeth, not in the support of the lip. This evaluation is part of the extraoral evaluation. Part of extraoral evaluation is to determine the lip support of our cases. We have clinical example about what we talked in the last slides. This is case with severe hypodontia and retained deciduous teeth. The patient came in this situation. The first step of our treatment plan is to take impression and prepare mounted study cast. After that, we can prepare wax-up of the case to see the final result of our case. Our goal or our aim is to reach this final result of the prosthesis. That means we start from the end. We design the final prosthesis. We design the prosthesis first. After that, we will see what are the options that can make us able to reach this final prosthesis. After we prepared the wax-up and we chose our treatment plan and our treatment plan steps, we prepared an immediate partial denture for two reasons. First reason, for the patient to see how his teeth will be shown after the final treatment, and for us as physicians or as doctors to see how is the final prosthesis and the relationship with the adjacent teeth, with the opposing teeth, etc. Another case, patient with missing four upper anterior teeth. The first step, we took impression for the patient and prepare mounted study cast. We prepare wax-up to see the final result. Now we have the final result. We will see what's the options of treatment. We have multiple options of treatment. If the space between the upper canines is wide, we can use 4 implants to replace the missing teeth. If the space between the two canines is limited, we can use 2 implants to support fixed prosthesis. If the patient has a problem financially, we can prepare third options to have fixed partial prosthesis between the canine and the canine. Or the patient can use removable denture. We don't have only one option, we have multiple options. We should design the prosthesis first, after that discuss with the patient about our options. Also, we should evaluate the functional considerations of our patient. Functional inadequacy is often assessed by interview rather than any specific measurement. There is variation between individuals variation between patient about the functional considerations. Patient Ahmad has more functional needs than patient Mahmoud. For example, how can we evaluate our functional considerations? We talk about the interview. We can evaluate our functional consideration. Plus, provisional restoration can be used to clarify the functional needs of our patient. The clinical examination of the implant patient consists of the extraoral examination, as we talk about lip support, how much of the anterior teeth revealed or shown during smiling, and we should evaluate the intraoral examination. We should make our intraoral examination as we see, as we talk about the evaluation of the degree of bone resorption, and we should evaluate the edentulous space or ridge that should receive our implant or receive our final prosthesis. In the intraoral examination, we should evaluate the height, the width, and the contour of the ridge of the missing teeth. Visual assessment and palpation can readily detect depressions and concavities, especially in the labial aspect. In this case, you see we have missing in the area of 1-1 and 2-1. We can see in the area of 1-1 maybe from the palpation and from the visual, we can see the bone is acceptable, is good. And from the palpation and the visual, we can see that we have bone resorption in the area of 2-1. But not always the visual assessment and the palpation can give us accurate assessment of the underlying bone width. Sometimes it will be difficult difficult to assess the width of the ridge of the bone, especially where is the overlying tissue is thick or fibrous. For that, we need an accurate assessment to evaluate the third dimension of the bone or the 3 dimension of the bone. We can have the solution of this problem, and we can have the accurate assessment of the underlying bone width by using 2 measurements. First measurement is ridge mapping. Second measurement is a 3D topography. These 2 assessments are used to accurately examine the bone profile and the 3 dimensions of the bone. Ridge mapping means evaluate the exact dimension of the bone and the soft tissue. For ridge mapping, we can use periodontal probe or special design caliper. This instrument you see in the picture is caliper. It's a special instrument to evaluate the buccolingual dimension of the ridge. This instrument provides with 2 needles. First needle will penetrate the soft tissue until it reaches the bone from the buccal side. The other needle will penetrate the soft tissue until it reaches the bone from the lingual side. We can read in the scale what is the exactly width of the ridge or of the bone in the edentulous area. As I told you, the only accurate assessment to know the third dimension of the bone is the ridge mapping and the 3D topography such as cone beam and CT scan. The mesiodistal dimension of the edentulous ridge can be detected by the study cast. The vertical dimension of the remaining bone can be detected by panoramic view, but the buccolingual dimension of the bone, we can't assess this dimension except by using the ridge mapping or the 3D topography. For example, in this case, we have a CT scan for this patient. The CT scan has one panoramic view. This panoramic view is provided with vertical lines. Each vertical line has a number. We need to put implant, to place implant in the area of 2, 3, for example. We will see the vertical line which pass the area of 2, 3, the tooth 2, 3, the upper left canine. We found that this number, for example, is 30. We will search for the slide number 30 in the bottom of the picture. We can see the slide number 30. From the slide number 30, we can see, measure the buccolingual dimension of the bone in this area. In the evaluation of the edentulous ridge, we should evaluate the profile and the angulation of the ridge and its relationship to the opposing dentition. That means we should have an adequate room for the prosthodontic component. In this case, we see the patient has missing in the area of 2, 1. If we notice that that we don't have adequate room for the prosthodontic component, that means we should create enough prosthodontic room. We should create enough room to receive our prosthodontic components. In this case, we have limited room to receive our future prosthesis. This limited room to receive our prosthesis due to limited vertical dimension or reduced vertical dimension due to missing in the molar area. The ideal solution for this treatment, the ideal solution is to make crowns in all of our the upper teeth and increasing the vertical dimensions. After that, we can insert our implant with normal room for prosthodontic component in the anterior area. Or we have another solution. If the vertical dimension is acceptable from the patient and we have enough posterior stop of this case, we can be realistic and we can make some bone reduction in the anterior area. After that, we can insert our implant. The reduction of the bone in the anterior area is to create enough room to receive the prosthodontic component. This is example of the realistic of the treatment plan. The proclined ridge forms will tend to lead to proclined placement of the implant that could affect the loading at the aesthetic. That means if we have proclined bone or resorption bone that which make the bone proclined, if our implant follow the bone, the implant angulation will be proclined which will affect the aesthetics and the function of the final prosthesis. The ideal solution for this problem to prepare and to design the prosthesis first, and our implant must follow the final prosthesis, not follow the bone, because if we follow the bone, we will have bad result aesthetically and functionally. As we always talk, our golden rule, design the prosthesis first. Design the prosthesis first and start from the end. That means start from the prosthesis, and our implant must follow the prosthesis, not follow the bone, because if we follow the bone, we will not have the ideal result aesthetically and functionally. We should evaluate the vertical dimension for the implant or the interarch space, because the increased vertical space will result in a prosthesis with an increased vertical height that will be subject to higher leverage forces. In this case, as you see, the vertical height or the interarch space is very increased due to the severe bone resorption. If we insert our implant, the final prosthesis will be very long. This will affect the biomechanics of this case. Will result in failure of the implant or overload of the implant. In this case, we should build the bone. We should graft the resorbed bone before we place the implant, to have ideal or enough vertical space, not increased vertical space and not decreased vertical space. Horizontal discrepancies between the jaws might require prescription of an overdenture treatment or extensive grafting or orthodontic surgery. If the relationship between the two jaws are class 2 or class 3, to solve this problem, we should in the ideal option to make orthodontic surgery, okay, to make orthodontic surgery to create it to class 1, or to make extensive bone graft to create the relationship class 1. Yani if we have class 2, we should make extensive graft in the mandible. If we have class 3, we should make extensive graft in the maxilla before implant placement. Or we can be realistic. The third option after grafting and orthodontic surgery, to be realistic, which is overdenture solution. Overdenture solution is a prosthesis supported by implant, can support the soft tissue and the teeth, and change the relationship from class 3 or class 2 to relationship class 1. This is example for the large horizontal discrepancies between the jaws. In this case, we see that the severe resorption in the maxilla due to the extraction of the upper teeth that lead to class 3 relationship between the jaws. The options of this case to make orthodontic surgery, okay, to make the relationship class 1 again, or make extensive bone graft in the maxilla to make the relationship class 1 again, or we can be realistic and we will use the overdenture solution to make the relationship class 1 again, and this prosthesis will replace the soft tissue plus the teeth and making the relationship class 1 again. We should evaluate the soft tissue thickness and the keratinized tissue amount in the edentulous ridge before implant placement, because keratinized tissue provide better peri-implant soft tissue than non-keratinized mobile tissue as the natural teeth. If we don't have enough attached gingiva, the patient will have gingival recession and another mucosal problems. That means if we don't have enough keratinized tissue amount around the future implant, we should create this keratinized tissue before implant placement by gingival grafting before implant placement. After that, we can insert our implant in ideal keratinized tissue around this implant. Distal dimension of the edentulous ridge is very important and to receive the implant in the ideal width or diameter. Best measurement of the mesiodistal width by using calipers or millimeter ruler, maybe clinically in the mouth or on the cast. We should evaluate the space mesiodistally between the tips of the crowns, between the tips of the crown and in the maximum contour of the crowns and at the level of the edentulous ridge. As you see, we are measuring the mesiodistal dimension of the edentulous area of the missing tooth cervically, and we should measure this dimension in the area of the tips of the crowns of the adjacent teeth and in the maximum contour of the crowns, that mean in the middle part of the middle part between the cervical and between the tips of the crowns. Mesiodistal dimension is not necessary only in the crown area, but it's very important to evaluate the mesiodistal space between the roots. Okay, in the edentulous area, we should measure the mesiodistal dimension in the crown area and between the roots, if we have enough space between the roots to receive our future implant. To evaluate the degree of bone resorption or to evaluate the quantity of the bone, we have the classification of jaw resorption as described by Cavod and Hovell, 1991. This classification has 6 classes. Class 1 is the dentate ridge. That means the ridge with the teeth. Class 2 is the ridge directly after extraction. Class 3, we mean by class 3 that we have a round ridge with sufficient height and sufficient width of bone. Class 4, that we have insufficient width of the bone, but we have sufficient height of the bone. That means we have horizontal bone resorption. Class 5, we have insufficient height of the bone and insufficient width of the bone. That mean we have resorption both in vertical dimension and horizontal dimension. Class 6, that we don't have enough bone to receive our implant. We have depression, insufficient height, insufficient width, and we have depression in the bone in this area. The picture in the right show wide ridge. If the X-ray show us good vertical dimension, that means this class will be class 3. That mean we have enough vertical dimension and enough horizontal dimension of the bone. While the picture in the left shown flat ridge, mandible ridge. That means this class will be usually class 5 or class 6. That means we don't have enough vertical dimension and we don't have enough horizontal dimension. The previous classification we talked about is for the bone quantity. We will talk now about another classification of bone quality. This is misclassification of bone quality. We have 4 types for bone quality. The type 1 or D1 bone type, this type of bone is composite of almost completely cortical bone. This class, we can find this class usually in the anterior area of the mandible. This bone is very dense. The density of this bone is more than 1,250 Hounsfield unit. Hounsfield unit is the unit to measure the density of the bone. The D2 bone type, another type of bone is D2 bone type. This bone composed of thick crystal layer of cortical bone and dense core of trabecular or cancellous bone. This type of bone, we can find it in the anterior and posterior area of the mandible. The density of the bone will be between 850 and 1,250 Hounsfield unit. The third type of bone is D3 bone type. This bone is composed of porous crystal layer, thin crystal layer of cortical bone and fine trabecular bone underneath the cortical bone. This type of bone, we can find it in the anterior and posterior of the maxilla and in the posterior area of the mandible. This type of bone, we can find it, the density of the bone in this type of bone is between 350 and 850 Hounsfield unit. The fourth type of bone is D4 bone type. This type of bone is composed of primarily fine trabecular bone. There is no cortical bone. All of this bone is cancellous bone. this bone will be found in the posterior area of the maxilla. The density of the bone is less than 350 Hounsfield unit. Which type of bone is better for implant placement? To answer this question, we can say that to have successful implant, we should have two factors: primary stability and osseointegration. Primary stability created by cortical bone. Osseointegration created by dense cancellous bone. In type 1 or in D1 bone type, we have excellent primary stability, but we don't have enough blood supply for this bone. That means the osseointegration will be limited. In D4 bone type, we have limited primary stability because there is no cortical bone. We have limited osseointegration because we don't have dense cancellous bone. While in D2 bone type, we have thick layer of cortical bone that will provide by excellent primary stability, and we have dense cancellous bone will give us excellent osseointegration. In D3 bone type, we have acceptable primary stability because we have thin layer of cortical bone, and we have acceptable osseointegration because we have acceptable density of the cancellous bone. That means the best bone for receiving our implant is D2. After that, D3, because we have acceptable primary stability and osseointegration, while D1 is not good for implant placement because we don't have good blood supply and we don't have good osseointegration. D4 is not good because we don't have primary stability, we don't have enough osseointegration. Study cast and diagnostic workshop. Why study cast and diagnostic workshop are very important in our treatment plan? In my opinion, the study cast and diagnostic workshop is the most important step in the preparation of our implant treatment plan, because study cast determine and the workshop determine the number and the position of teeth to be replaced and their relationship to the opposing dentition and the adjacent dentition. The study cast and diagnostic workshop can be converted into provisional restorations. We can make provisional restoration according to our study cast and diagnostic workshop to be evaluated in the mouth for the patient to see the future of the case and give us his evaluation and his notes about this design, and for us to see the functional requirement of the patient. The study cast and workshop used to construct stent or guide for radiographic imaging and implant surgical placement or surgical guide. That means from the workshop we can prepare the radiographic stent and the surgical stent. What is the radiographic stent? Radiographic stent is an acrylic denture clear acrylic denture can be used from the patient. We will put some radio opaque material in this acrylic denture. After that, we will take the patient will receive the X-ray while he is wearing this acrylic denture. Because this denture is provided by radio opaque material, we can from the X-ray recognize the position and the location of each tooth need to be placed by implant in our treatment plan. After that, the same radiographic stent can converted into surgical stent. We can use this surgical stent to make the drills to guide us during our procedure in the implant placement, the drilling to prepare the site of our implant. The stent will help the clinician, the surgical stent, to decide the optimum location, the number and the type of implants, and guide the placement of the implant in the optimum location. Diagnostic wax-up and the provisional restorations are very important to assess the appearance of the planned restorations. As I told you before, start from the end and design the prosthesis first. Look at this case. We have missing in the area of 2-1. We have a trauma in the area of 1-1 and 2-2. Our treatment plan was to extract the teeth number 1-1 and 2-2. After that, we will prepare a treatment plan, a design that replacing the 3 teeth 1-1, 2-1, and 2-2. For that, we took impression and prepare wax up to replace the teeth 1-1, 2-1, and 2-2. Now we design the prosthesis and we see the future of the case. The second step after preparing the wax up, we convert the wax up into a radiographic stent. This is radiographic stent. What is the radiographic stent? As I told you, it's a clear acrylic denture, provided with radio opaque material. To be shown in the X-ray when we take the X-ray for the patient. We can use multiple material as radio opaque material in the radiographic stent. In this case, we try three different material. In the area of 2-2, we use barium sulfate material to be added to the area of 2-2. In the area of 2-1, we put Cotaberca. In the area of 1-1, we make painting of temporary bond from the buccal side. That means in this case, we try three different material to be added to the radiographic stent. We can add another material such like wires, metallic wires, or foils, or amalgam, or another material radio opaque. After we prepare the radiographic stent, the patient uses this radiographic stent, and we take the CT scan from the and we take the CT scan. Now, after we take the CT scan while the patient using the radiographic stent, we can measure the 3 dimensions of the bone in the area of our missing teeth to design and to prepare our ideal distribution of the implant in the future. If you see now in the panoramic view, we have the area of 2-2, clear the area of 2-2. It's from the panoramic view. This is the area of 2-2. We will see if we have enough bone to receive our implant, and we can measure the buccolingual and the vertical dimension of the bone in this area. We can see the cross section of the bone in the area of 2-2 from the group of the slides in the picture number C in the bottom. If you see, the area of 2-2 is the last two bottom slides. In these 2 slides in the bottom right, in the bottom right, we can see the 3 dimension of the bone. Okay, while the area of the area of 2-1 with cotaberca is the shown in the 2 left slides, 2 left bottom slides. We can see the buccolingual dimension of the bone. The area of 1-1 of the temporary bone, it's clear. It's clear in the upper slide, and starting from second slide, from second slide to 4th slide, starting from the right. Okay, we can measure the buccolingual dimension of the bone from these slides. I will give you a summary about the our steps to prepare ideal treatment plan for implant restoration. When a patient visit us for implant placement, we will take the following steps with him. First of all, the examination, clinical and initial radiograph is very important. Second, we will take impression for the patient and prepare mounted study cast and diagnostic workshop. Start from the end, design the prosthesis first. After we prepare the diagnostic workshop, we will prepare provisional restoration, such as removable dentures, and we can take specialized radiograph if it's required. From when the patient wear the provisional restoration, we can discuss with him the treatment options, and we can prepare our final decisions of the restorations. After that, we should complete any necessary dental treatment, perio treatment, resto treatment, endo treatment, extraction, all of this before implant placement. After that, we will prepare the provisional or transitional restoration to be ready before implant placement, to use this provisional restoration directly after implant placement. Later, we will change the provisional restoration into radiographic stent, into radiographic stent to be to help us during our radiographic assessment of the case and decision of the number of the implant and the distribution of the implant. Later, we will change this radiographic stent to surgical stent. This is the same of the radiographic stent, but we will use this stent to help us during the drilling of the implant site. After we prepare the surgical stent, we will place our implant in the bone. After that, we will wait for adequate time to have the healing and the osseointegration. After the osseointegration, we can start the prosthodontic phase. I will tell you now about Alperkson minimum success criteria. Dr. Alperkson put 4 or 5 criteria to define the successful implant. First criteria is that an individual unattached implant is immobile when tested clinically. That means the successful implant should not show any mobility when tested clinically. Any mobility means that this implant is failed implant. 2. Radiographic examination doesn't reveal any peri-implant radiolucency. 3. After the first year in function, radiographic vertical bone loss is less than 0.2 millimeter per year. That means after we put the final crown, we can accept only by 0.2 millimeter bone loss, vertical bone loss per year. But more than 0.2 millimeter per year of bone loss is not acceptable and doesn't mean that is a successful implant. 4. The individual implant performance is characterized by absence of any signs and symptoms such as pain, infections, neuropathies, paresthesia, or violation of the inferior dental canal. The 5th criteria, as a minimum, the implant should fulfill the above criteria. We mean the 4 first criteria. With a success rate, we can say that the implant is successful if the implant fulfill the first 4 criteria by 85% after 5 years observation period and 80% at the end of 10 years period. Yani if the implant reach the first 4 criteria, it's not necessary to have completely 100%. If the implant reach 85% of the 4 first criteria after 5 years, we can say this implant is successful. And 80% after 10 years, we can say this implant is successful implant. Alperkson put 3 categories of implant success rate. First, the success rate, that means fulfill the criteria of Alperkson. Second, failure rate, That means the implant that have been removed from the mouth. There is خلاص, bye bye. 3, survival rate. It's not successful implant, not success rate, and not failure rate. Something in between. Implant remain in function, but don't match the success criteria of Alperixon, such as implant with some gingival recession, implant with bone loss more than 0.2 millimeter per year, but doesn't moved from the mouth. This is the survival rate. Thank you so much and good luck.